Elliot Froman.
Elliot, Bob Lissack on.
Oh, hi, Bob. Fabulous. Great. Bob was on with our first inaugural webinar, Difficult Case Conference, which was fabulous. By the way, for those of you who have missed the first two, this is the third. These are now archived on the website at the National MS Society, and I would strongly encourage you to listen to those. The first inaugural session, Dr. Lissack contributed abundantly to the presentation of that very, very interesting patient that turned out to have neurosarcoid, and presented by Andy Romeo from UCSF. So thanks for coming back again, Bob. And I think without further ado, I think Doris will go to the slides, and we'll let our presenter, Brandon Moss, begin. And remember the rules of engagement. We're going to let Brandon move through the slides. Brandon, give a little bit of time after you've presented what's on the slide, just in case there are any questions from the field that could include fellows as well as faculty and faculty mentors. That's the point of this, and there'll be questions. And while we're getting the slides booted up, one final item, and that is we are in discussion with Neurology N2, Neuroimmunology and Neuroinflammation, to hopefully publish the proceedings of these Difficult Case Conference webinars in a CPC kind of format. And I look forward to working with both the fellows, but also a number of the faculty mentors on putting those together and having them published. So we should have it definitive pretty soon. I've been working with Kathleen Costello of the Society, but also Scott Zamville, who's the deputy editor of Neurology N2, with Joe Dalmu, who is the editor-in-chief. Okay, so Doris, are we ready for that transition to slides?
Yes, Brandon,
Yes.
I just prompted to make you the presenter, so you should have gotten a little notification on your screen to go ahead and share your screen.
Okay.
All right.
And Brandon, do we have a camera for you? I'm sure that it would be great to see you live and in action.
Sure, let me figure this out here just a second.
I've taken myself off, so I'm not a distraction. By the way, I wanted to also make sure that I didn't forget to welcome again, I did it early, Steve Galetta is on and will be on with us for the session as the chair of neurology at the NYU Langone Medical Center in New York.
Hello.
Hey, Brandon.
Yeah.
Okay, there you go. All right, you're in full slide
Am I
mode.
on?
Yep.
Does Brandon want slideshow instead of this view? I'm seeing both this slide and the next slide.
I am as well. I think we want to open to view slideshow.
Okay.
Yeah.
Same thing.
That's
Yeah.
the way. That's the way. It's.
Yeah, are you using two screens?
It does have two screens. Yeah. Yes.
Yeah, so you need to make sure that on your when you're showing your screen, just choose the screen that has the presentation, the slideshow view, and not the notes view.
Yeah. Thank you for muting that phone with the background noise. It sounds like you're filming an episode of House. That's great. Okay, Brandon, it's all yours.
All right, give me just a second. Still trying to figure out the technical issues here.
Well, if it's the camera, forget the camera. We'll just listen to you.
Okay. Does this work then, having it in presenter mode?
Yeah, I think that works. It's unless we can go to a single screen. If not, just let's go with this.
All right. We'll just go with this. Okay. So The case is a 65-year-old man who presents for a second opinion regarding diagnosis and management of multiple sclerosis. So he came after he had 14 months of progressive difficulties speaking and swallowing. This began with some mild slurred speech. Then he developed a strained voice, and then he developed speech that was only intelligible to his family. He also had some problems with swallowing, first with liquids and then with solids. And he developed a 40-pound weight loss over the past year prior to coming in. He also reports some difficulty walking upstairs.
Before you go to the next slide, Brandon, it's Elliot. I just wanted to ask, it may be obvious to everybody, but when you said 14 months of progressive dysarthria and dysphagia, the other question I'd like to ask is just historically, going back remotely, we don't have any history that there was any remote neurologic history prior to 14 months, or are you going to tell us about that?
I'm going to tell you about it.
Thanks a lot. Okay, great.
So 2 months before the visit, he was diagnosed with multiple sclerosis and was started on Tysabri. He is tolerating Tysabri and continues to note progression of symptoms, but it's only been 2 months.
So I could ask a question, Brendan. It sounds like he didn't have much, if anything, until the 14 months. You're going to tell us about this remote history, but it sounds like he was essentially normal function until 14 months ago.
That is correct.
Okay.
And for those of you who don't recognize the voice, that's Bob Lissack, just so we're all on the same page. Very important. Okay, keep going, Brandon.
And so when asking him about prior neurologic symptoms, he reports that he first noticed the symptom 31 years before with about 3 days of bilateral loss of vision. He recovered vision in the right eye, but had some persistent deficits in the left. At that time, he had an MRI and was told that he had possible MS, but he was never treated for it.
Did he recollect any discomfort or pain in the eyes at that time, Brandon? Does he remember?
Yes, he did.
He did. Okay.
So, Steve Gillette, it's very unusual for typical demyelinating optic neuritis to present with bilateral visual loss, maybe 0.4% of cases. So when you hear bilateral visual loss like this and you're thinking about optic neuritis, it does shift a bit to NMO and to MOG, which is really possible. NMO would be interesting here, given the dysphagia and dysarthria and this history of bilateral visual loss.
Right. Absolutely.
And to Steve's point, and I don't know if we have any pediatricians on the phone, that we would agree that bilaterality and probably also anterior optic neuritis or papillitis more common in the pediatric age group, but obviously not the case in this gentleman. But just from the standpoint of,
yeah, for the question for both Steve and Elliot and Brandon, that much recovery untreated for NMO would be kind of unusual, wouldn't it?
Yes.
They don't do all that well.
Right.
It sounds like he was a little old for Leber's, and they don't do well either.
Yep. What's his?
They definitely don't do well. There are some variants with NMO where the patient, can have these fairly long periods between their episodes. And I have a patient who had about a 20 to 30 year period between her optic neuritis episode and then subsequently developed myelitis, and her acuities were in the 20-25 range. So not always a bad visual prognosis, but maybe in 50 to 60% of them, they're going to be over time less than 2200. So much greater chance that they're going to have that degree of visual impairment as opposed to a patient who has MS. The range much less, the much lower percentile range, maybe 5% of patients. So big difference, but not impossible to do well.
The other question I have for Brandon, and I assume
race.
There's no MRI scan available from 31 years ago to see why they said MS. Rather,
Right.
it would be a little unusual for NMO to have a classic-looking MS, but we don't have those. You don't have those to look at.
Right. Not available. Yeah.
One final issue before we let you go, Brandon. Maybe this was on the. Maybe I missed this. What is his racial designation? Is he Caucasian?
Caucasian.
Yeah, and this gets to the other issue that Steve Galetta mentioned, is that certainly there's been work to demonstrate that neuridities, and likely both with NMO, but also with neuridities associated with MS, where there are racial differences in terms of severity. And we have both Steve as well as Laura Balser on the phone, and we can all speak to the issues of the OCT and the effect of neuridities on a racial basis with respect to thinning of the RNFL and the GCL IPL. But Bob, your point is very well taken. And anyway, Brandon, we'll keep going and we'll have other comments.
Oh, sure. So I'm just going to go over the review of systems. Basically, there was nothing else. No problems with cognition, language, double vision, spasticity, sensory loss, paresthesias, pain, incoordination, problems with walking, bladder symptoms, bowel symptoms, sexual dysfunction, Lhermitte's, or fatigue.
Mm-hmm. And yeah, and you didn't have any sense that over the years there was anything that would have been reminiscent of Uthoff's phenomenon, either with the more typical heat sensitivity or the less typical inverse Uthoff's with cold sensitivity.
No, he never did. He just had the one episode of vision loss and then recovered as well as he was going to. Yeah. And then in terms of past medical and surgical history, really not much. He did carry the diagnosis of multiple sclerosis. And then medications, standard fare. He was on vitamin D3 after the diagnosis of MS. Really no allergy. Social and family history. He was a former smoker for many years, but quit after he developed these progressive symptoms. No alcohol use and no drug use. For family, he had a daughter with ulcerative colitis, but no other autoimmune diseases, and no neurological disorders in the family. And then getting to his exam. His language was difficult to assess due to the severe dysarthria, but he actually performed quite well on the things that I could assess. Oriented to person, place, time, and situation. His 5-minute delayed recall was intact. Again, I was relying on his family to interpret for me to some extent. Remote memory was intact. For his cranial nerves, doing quite well. Only mild deficits within the left eye with 20 out of 30. And that was with his glasses, though. There was no relative afferent pupillary defect that was apparent.
Brandon, what about fundoscopic examination? Any rudiments, evidence that there might have been some astrogliosis in the sense of having any pallor, any difference in color between the left and the right side?
Yeah, there might have been some mild pallor, but it was hard to say. They looked pretty comparable between the two.
Okay.
And then for eye movements full, there was no INO, there was no nystagmus. Some slowed saccadic movements with tracking. Facial sensation and facial movement were intact. His palatal movements were normal. And then he had full strength of sternocleidomastoid and trapezius. The tongue was midline, and he did have a severe dysarthria, and it had both spastic and paretic qualities, although spastic were by far the predominant.
So his gag reflex was increased, decreased, or okay?
I didn't test his gag.
And jaw jerk?
Jaw jerk was brisk.
Brisk. Okay.
And with the tongue sitting quietly in the mouth, did you notice fasciculations?
There were, yes. Yeah.
Mm-hmm. And then the other issue was behavior. Was there any evidence of any pseudobulbar affect in this gentleman?
There was not.
Okay.
And no ptosis, right?
No ptosis. Yeah. As we mentioned previously, there were tongue fasciculations. There were also fasciculations in the forearms bilaterally, but I didn't see anything in the lower extremities. And then he had really more of a generalized loss of muscle bulk throughout. There weren't obvious areas that were atrophied compared to others. In terms of his strength, 4 out of 5 strength within the left arm, really throughout. And in the right arm, it was primarily distal that was 4 out of 5, but otherwise full strength. In the lower extremities, he had some weakness of hip flexion and knee flexion, but was otherwise quite strong.
Brandon, did the gentleman have, or did you specifically look for any evidence of gynecomastia?
No, he didn't.
Okay. And for those...
And his tone, Brandon?
Yeah, his tone was actually normal. I didn't detect any increased tone.
Increase or decrease, okay.
Yeah.
And Brandon, just for the listeners who may not immediately resonate with the question I asked, is so why the issue of gynecomastia in a gentleman that has spinal bulbar manifestations?
Yeah, I'm thinking that you're getting at something like well, I guess I'm not entirely sure.
Yeah, so the issue is spinobulbar muscular atrophy, or Kennedy syndrome, and this may come up later. We talk about results of assessments in terms of, did we look at a CAG, trinucleotide repeat pattern in the testosterone receptor? So there are some variants of motor neuron disease, and this is a particularly important feature since a number of them have gynecomastia. Anyway, I'm sorry about that. I'll let you keep going.
A little old.
Oh, that's fine.
A little old
Yep.
for the onset.
Yep.
All right. So in his cerebellar examination, no evidence of dysmetria or dysdiadochokinesis. He had a narrow-based stable gait with some mild instability on tandem, but that was to be expected for age. And he was hyperreflexic throughout, which was more marked in the left arm and leg compared to the right. He did have extensor plantar responses bilaterally.
Yeah, I can tandem, and I'm older than this guy.
Yeah.
I believe you, but I want to see it. And I'll put Galetta next to you just to have a reference point there.
Galetta and I have played under the boards against each other, next to each other long enough.
All right.
I'm sure you can do well.
I rest my case. Okay.
And then for
Brandon?
sensation, his sensation was intact.
Okay.
So we did have some lab works that were sent before he arrived. So he had an elevated IgG index, and he had 14 oligoclonal bands that were present in the CSF, but not in the serum.
Mm-hmm.
And then we had an outside MRI report, but no images at this time, that talked about a moderate to severe T2 lesion burden and lesions characteristic of MS, as well as one enhancing lesion in the left brachium pontus. And this was around a year prior to when he presented to us.
Brandon, before you go on, I was wondering if maybe I could get perhaps Esther Malamed, our neuroimmunologist extraordinaire, with others on the line, of course, including Bob, to maybe comment on the oligoclonal banding pattern. And not so much that, yeah, can we see this, but just in terms of what does banding mean in terms of the range of diagnostic entities. Esther, are you there?
Yeah, so of course, a very good and very interesting question. We can see oligoclonal bands often in multiple sclerosis, and it's we don't quite know where oligoclonal bands come from, but it's the B cells in the CNS that are reactive to a multitude of antigens that are making these antibodies intrathecally that we observe as banding on a Western, and we call them oligoclonal bands. But of course, very interestingly, oligoclonal bands, although diagnostic in MS workup, are not very specific to multiple sclerosis and can be seen in other diseases, other inflammatory diseases. And so the question here with your very interesting presentation of this patient is we still have to keep a differential fairly broad, especially with all the data that you've provided for his motor examined dysphagia. So this would not completely tell us that yes, this is MS and nothing else. So it's interesting, it's contributory, but it's not diagnostic exclusively of MS in this patient.
As you said, it means inflammation, and it means B cells / plasmablast / plasma cell activity, infectious diseases, neurosyphilis, people forget, can do that. Behçet's can do that. Interesting, one of the leukodystrophies, adrenal leukodystrophy, is the one that can do that. And that's the one that can actually enhance MRI. Old work by showing the inflammation by Herb Schaumburg with Pierce Richardson.
Yep. Great point, Bob.
Not that he has that, but.
Well, I'm glad you brought it up. We'll get to the films. We have Nick Bryan on the line too, so perhaps we'll wait till we see those films because, again, the differential is broad, and I'm glad you brought that up. So, Brandon, we'll turn it back over to you, and we'll get to that point.
Sure. So he had actually had a swallow study at this point as well. And he had mild oral and moderate to severe oropharyngeal dysphagia with a high risk of aspiration, and they had actually recommended a PEG be done. So now I was just going to leave it up to the audience to suggest a differential diagnosis.
Yeah, so...
Just out of curiosity, did he have a CPK?
He did not at this point.
Okay, thanks.
So Josh, could you expand upon that a little bit? You asked about whether he had a creatinine phosphokinase.
So, I think if we looked at this case without the prior history of optic neuritis and without being told that he had a history of MS and we never knew about his MRI, this comes in looking fairly typical for motor neuron disease given his age and a combination of upper and lower motor neuron signs, paucity of sensory findings, brainstem findings, and diffuse fasciculations. A combination of upper and lower motor neuron, makes you think of motor neuron disease. And, to expect his CPK to be elevated. And the question that I have is there a unifying diagnosis where we could put these together? So Kennedy's would be a good thought, but the age is off. And then mitochondrial for his age, but I don't know what mitochondrial disorder does this exactly. So then I'm stuck with thinking, does he have two problems and he's just really unlucky? So that's sort of where I am with this.
And the one that he was advertised as having not being the key one.
Right.
Because he was basically asymptomatic from his MS if you attribute everything else to his motor neuron.
Right. That could happen. It's just a strange thing.
The CK might be elevated, but it doesn't have to be.
Right.
And
it's not really going to give us more information.
Yeah, I mean the EMG and the clinical is more important than the CK.
Right. Yeah, it wouldn't really help. I'm just curious.
Somebody has some background. If you could go on to mute, that would be great. Lindsay, do you have some input for us on differential other than what's been mentioned already from the standpoint of MS motor neuron disease? Any other things that you guys in Colorado would be looking at in a patient like this?
I don't really have much to add. My first thought was definitely motor neuron disease with this clinical presentation. So I don't have much to add to what's already been discussed at this time.
Yeah. I'm sorry, go ahead.
Hi, this is Pilar from Columbus, Ohio. And so it seems that the patient had a history of smoking, right?
That's correct.
And have anybody looked into the possibility of paraneoplastic?
Okay, very good thought. And I think Brandon is going to get to some of that. That's an excellent idea and one not to miss. Certainly he's undergone a smoking cessation program relatively recently, but your point is well taken. Even if this was remote cessation of smoking, these things can rear their heads later. So your point is an excellent one, and I believe he's going to make some commentary about that.
Yes.
Ed Fox, any additional comments on the differential before we move on?
Well, I think that what we discussed about motor neuron disease was being discussed about the weight loss, the progression of the disease as it stood, really stands in the face of everything that we're going to anticipate for multiple sclerosis. So I'm always appreciative when I hear a story like this where people take a step back and say, you know what, yeah, he may be on the strongest MS medicine we have, but there's a reason why he's not getting better, and we need to find that out. So, I mean, I think the differential, we've spelled it out. I don't need to add much. I just think this is a very good call to do additional testing.
There have been cases with PML affecting the brainstem, but he hasn't been on Tysabri all that long, and I don't believe they would have fasciculations and stuff in his fasciculations in his forearms. It doesn't make sense. The only other disease that you think about with arm fasciculations in a man and tongue fasciculations would be MMN, but nothing else fits, so I wouldn't think very seriously about it.
Okay.
All right, and I was also going to ask what additional studies would you order? Oh, I didn't hear that.
Well, I think obviously you're going to look at imaging. I think it was already mentioned about, very importantly, would be EMG and nerve conduction studies. I don't really look at those as tests. They're really more extensions of our exam, albeit physiologic in nature. So that's going to be, I think, absolutely critical. And I heard some commentary earlier about his visual loss, the remote visual loss, about labors, and then this subsequent story. But trying to put into context whether he had or really ever had MS would raise the spectrum in terms of whether we would consider looking at paraneoplastic, mitochondrial cytopathies, nutritional agents. Bob had mentioned syphilis before. I would really take a hard look at those 14 oligoclonal bands and just make sure that we have a reasonable differential of inflammatory, infectious, and has been mentioned, other conditions like leukodystrophy, and specifically adrenal leukodystrophy, which has been raised as a potential prospect of producing that. But this, in fact, would be extraordinary, except to say that we do know that upper and lower motor neuron manifestations can occur in demyelinating diseases of the leukodystrophy type, particularly metachromatic leukodystrophy, adrenal leukodystrophy, the very unusual Cockayne syndrome, and of course in Krabbe's disease. But other suggestions from the field. Eric, any suggestions you would have for us? Eric Kildebeck at UT Dallas?
No, I've enjoyed the discussion so far. And I can see the next slide, so I'm looking at the imaging.
Okay. Yeah.
Probably shouldn't be.
So maybe, well, that's fine.
Has anyone discussed sarcoidosis?
We have not, but I'm assuming that's you, Lindsay?
Yes. Sorry.
So sorry. Sarcoid's always on the list, Lindsay, as you learned from probably episode 1 of the TV show House, and it's almost never sarcoid, except in Andy Romeo's beautiful presentation at our inaugural webinar a number of weeks back, where it turned out there was a myelitis, and then there was a discussion that Bob Lissack and I had about this sort of stretched out bubblegum leptomeningeally based lesion, and Andy did a beautiful presentation as well as his workup, and actually did confirm that that was in fact a patient with confirmed neurosarcoidosis. So always on the list. I would say this would be pretty unusual from a number of vantage points, but
the CSF formula, as Brandon gave it, doesn't really fit or the clinical, and then we have the imaging. They rarely have bands. They have low sugars, high cell count, high total protein. We just had a patient with that, and we actually had the CT surgeon following Sutton's law take a note, and he's got non-caseating granuloma. But his glucose in his CSF was 40 with a blood of 120, had 300 white cells, and no bands.
Right, and I didn't present the full CSF results, but they were normal except for the oligoclonal bands and IgG index.
Right. And lower motor neuron disease would be peripheral neuropathy, yes, but lower motor neuron disease, I wouldn't say no, but I would say very unusual.
Radiculopathies, though, yes.
Yes.
But my patient actually had enhancement of his lumbosacral, his cauda equina with gadolinium, which is another clue.
Yep. And I have to give you mission before we keep going. When I was in training at Hopkins, I saw a number of patients who ended up having confirmed neurosarcoid that I saw with Vinay Chaudhry and with David Kornblath. And these were patients who presented actually with a rapidly evolving, what looked like a necrotizing vasculitis, peripheral neuropathy. And I'm not happy to tell you, but the fellows are on, so I think it's always good to be honest. I missed every one of those diagnoses, wasn't even on my list. And the biopsy of the sural nerve actually demonstrated an ocean of non-caseating granulomas in those patients who had no lung involvement, no findings of adenopathy, just a rapidly progressing necrotizing vasculitis. We were looking for vasculitis, we were looking for amyloid and other things, and lo and behold, they had sarcoid. So it must have been 3 or 4. I missed the diagnosis in all of them. But I would say, in somebody you're considering this sort of story about something rapidly moving on a peripheral neuropathy basis, sarcoid would definitely be on the list. But very unusual for diffuse fasciculations and a spinal bulbar set of manifestations.
And this is no sensory findings, which would be,
yes,
you know, not it would be have to be a motor neuronopathy. So we're back where we started.
That's exactly right. Although I would say on the Kennedy story, a little older, I was presented a patient in Austria a number of years ago who was quite age advanced that was told to me as having testicular cancer and had tamoxifen and, you know, trying to drive me away from the obvious body habitus, which included when I took his smock off, he had gynecomastia and a fasciculating tongue, and they had just gotten the trinucleotide repeat back and had Kennedy's. But in those patients, in those circumstances, sensory manifestations actually can be seen not infrequently. So there's a variant, a nuance of motor neuron disease where sensory manifestations are not unexpected. Okay, Brandon, so you want to present the MRI?
Yes. So here are the images. You can see that he's got multiple lesions, almost confluent now, and also some evidence of atrophy here as well. Here you can see around the corpus callosum, it looks like he has the typical Dawson's fingers type lesions, but they have just sort of grown together over time.
Before you go on, could I have, again, I mentioned earlier, we're very fortunate to have Nick Bryan on the phone as our director of neuroradiology, but Nick, does this strike you as being a sort of typical chronicity, long-standing demyelinating disease, or what other things might you help us with in looking at these image characteristics?
Can you hear me? My microphone working?
Absolutely.
Good. Well, yeah, this would be fine for a chronic MS. Basically, the first alternative, obviously, would be just an older person with hypertension and small vessel disease, and I don't think you emphasized that he had a particular history of hypertension.
He did not.
No. So then, on the other hand, you mentioned a number of other diseases that could have this appearance. There's certainly nothing specific about this, but Behçet's, some of the leukodystrophy, that's often all older person. There are a few variants that do present at this age. Likewise, rarely mitochondrial at this age. Syphilis can look like this. Sarcoid, of course, as you mentioned, can look like anything. What, of course, doesn't look like this alone is motor neuron disease. But the combination, on the other hand, you know, that would be perfectly fine. So, yeah, this would be perfectly consistent with chronic MS, but there are a number of other things that could look like this, and dual diseases would certainly.
If you look at the axial and ignore the anterior, the confluent lesions towards the posterior look like you see in adrenal leukodystrophy. But when you look at the sagittal and you see the Dawson finger-like, and on the back to the axial, you can see like a U fiber. That I wouldn't expect in adrenal leukodystrophy. But if you cut off the front and just look at the back, adrenal leukodystrophy can look like that.
Yeah.
This is Doris, and I'd like to jump in with a question that's on the chat from Daniel. He wants to know if there are any images of the brainstem, and was there flow or cytology on the CSF?
So there was no flow or cytology on the CSF, and we did get images of the brainstem, which actually looked quite unremarkable. There was, I think, a hint of a lesion around the left brachium pontus, where he had an enhancing lesion about a year prior. But other than that, it was relatively intact.
Okay, so we can keep going.
Yeah. And this slide is just to reiterate that there were no enhancing lesions on the MRI that we got. And we did send JCV serologies as well, and he was positive at the time.
Was the spinal fluid assessed for JC virions? Not that we think this is characteristic, but and he's on the drug for a very short period of time. But if you had the fluid, yeah, could be sent.
It was not. It was not.
Okay.
Apparently, the fluid was done elsewhere, right, Brandon? So
that's correct. That's correct.
Okay.
Yeah. Yeah.
So this is Nick. Just wanted to ask a follow-up question about MRI. So you're saying that the brainstem and I assume the rest of the posterior fossa were relatively unremarkable.
Yes.
And this who's got a lot of bulbar symptoms are now going to the pseudobulbar. So, but that posterior fossa brainstem really looked pretty unremarkable, huh?
That's correct.
Mm-hmm. Which raises the specter of there are dogs with ticks and dogs with fleas, and perhaps here there are dogs with ticks and fleas.
Brandon also mentioned that he had a mixed bulbar and pseudobulbar, and that's why I specifically asked about the jaw jerk, which we were told was brisk. There's another reflex that people forget about, which is called the corneal mandibula. Yeah, so when you do the corneal, everybody looks to see if how the eyelids close. If you keep an eye on the jaw, you see if it deviates, and that's sort of similar to an increased gag or an increased jaw jerk. So it would go with a lot of his being pseudobulbar, which would go with ALS or MS or both.
Sure.
And do you know if there was any susceptibility artifact in the motor cortex on the MRI? The only reason I ask is recently had a patient who had a kind of a prolonged course until diagnosis of motor neuron disease, ended up having this kind of beautiful susceptibility artifact bilaterally in the motor cortex, kind of just due to iron deposition from those motor nerves dying. So it could have been a clue on the MRI. I mean, I see that there's the EMG data now, obviously that's definitive, just to kind of help us out.
No, that was none of it. That was not present, yeah.
So Ethan, you're referring to the analogy of like heart failure cells in the lungs, except these are neurons and undergoing degeneration with iron deposition.
Exactly.
Yeah, it's a great point. By the way, one other point about, I know we've got Laura and Steve on the phone, Laura Balls and Steve Galetta. Bob Lissack, you made a nice point about the oculomandibular, but we also know during the normal exam you can see people who have oculomandibular synkinesis, where during the testing of saccades with eccentric eye movements, you can see jaw deviations as well, which, by the way, can be normal, but when really brisk and hyperreflexive, may be more likely to be seen in association with these disorders. Okay, so we're going to talk about the EMG. This is perhaps tantamount of everything we're looking at.
Right. I'll just preface it saying that the nerve conduction studies were normal. So really this is just the motor findings, and you can see that he's got fasciculations in the arm and the leg on the right side.
And very important for those nerve conduction studies. So for any of the commentary that Bob may have made or I may have made about leukodystrophies or having upper and lower features of demyelination, central and peripheral demyelination, we certainly did not find it on nerve conduction studies.
Correct.
And we do know that neuropathy, peripheral nerve involvement with leukodystrophies like adrenomyeloneuropathy or adrenoleukodystrophy, those can be demyelinating, axonal, or mixed. So it's important to point that out. These are not purely of one pathology or another.
Sure.
Besides the six, I mean, he has all sorts of evidence for neurogenic disease, and he's got it in multiple segments.
Right.
All right, and so as part of the additional workup, this is before the EMG results, we also got a paraneoplastic panel, and we got a heavy metal screen, and all of those results came back and were negative.
Mm-hmm. By the way, he had obvious tongue fasciculations. Sometimes the examiner maybe a little exuberant or may overcall, but was the tongue needled during the EMG? And
No, it was not.
yeah, okay, but the tongue and the mouth looked pretty, lying quietly, looked pretty
Yes,
obvious.
that was classic. And then in addition to that, he had a spastic flaccid dysarthria, really. So,
Gotcha. Okay.
Yeah. And so then, what is the diagnosis? Which I think everybody has really reached the same conclusion now.
Well, you never know. We have our detractors, and you know, for this, I would have to go to Ethan Meltzer in Boston. And not that you're a detractor, but if you were Ethan, how would you call this something other than motor neuron disease, or in this case, ALS, based on what you know now? Or would you say, I really can't come to any other conclusion unless Brandon changed the names on the report and we're looking at the data from a different patient?
I don't think that you can come to any other conclusion based off that data.
And what was the spine MRI in this case?
Yeah, he didn't have any spinal cord lesions.
Yeah, but the other question that was being asked there is about spinal imaging in particular, because obviously this is a monumental and very ominous diagnosis. The question is, what other conditions could produce diffuse fasciculations in these myotomal segments? So clearly one wants to make sure that we don't have a compressive, mechanical, radicular, notwithstanding, again, the absence of sensory, pure motor, but be careful. Clearly for boards and for rounds, there are other conditions you'd want to know. So I think the question about spinal imaging that was just asked is a very important one.
I just find it incredibly shocking that all of the disease is supratentorial in this case, and there's no brainstem or spinal cord disease in somebody who had optic neuritis, has 14 bands in their CSF. It's extraordinary. I just want to make sure that there isn't anything in the cord, either extrinsic or in the cord, that might, generate fasciculations. Because clearly somebody with all of this disease, as Bob and Nick Bryan was suggesting, could have pseudobulbar disease that resulted in some of the dysphagia and dysarthria, and we're relying a lot on the presence of the EMG and fasciculations here.
But if you go back,
if you wanted to
go back to the EMG, and the question is, does he have it in sufficient segments to meet the criteria, the modified L-Ascorial? And I think he does, and he'd have to have compressive disease in the cervical, thoracic, and lumbosacral. That's possible, but pretty unlikely.
Right. Great point.
And then you have bulbar with the tongue. I mean, the tongue can't be. The tongue could be pseudobulbar and bulbar, but the 6 is bulbar.
You bet.
All right. So we reached the conclusion that he had both MS and ALS, with ALS being the driver of his symptoms. And then the corollary question that I have is, how would you manage this patient?
Okay, so maybe just to get a little architecture put onto that question, Brandon, let's talk first about the management from the standpoint of the disease process itself, and then dichotomize that with the multidisciplinary management of this guy's symptomatic and other issues, right? Swallowing, risk of aspiration, breathing, all those sorts of things. Let's telescope first just on the issue of disease modification, and what do we have from the standpoint of here, the disease which one eclipses the other, obviously the motor neuron disease over MS. So the question—
You could even argue, Elliot, that he has benign MS.
Yes.
Fits the clinical criteria, 30 plus years with 20/30 in one eye.
Yes, I would agree as far as that criteria, right?
Yeah.
So now the question is, what do we have to offer this man today, based on the fact that we're going to say that ALS is the principal diagnosis we're going to focus our therapeutic intervention on. And to my knowledge, there are only 2 FDA-approved drugs, Riluzole and and the recent agent that was just approved by the FDA recently. So what are our options? So we can open that up for discussion. Well, Brandon, tell us what you were thinking. You're the fellow. What do you have to offer this gentleman with ALS?
Right. So we sent him to our neuromuscular clinic where they did offer him Riluzole. But primarily the focus was on symptomatic management. And so he actually had a PEG tube placed consistent with his wishes. I don't have the results of his breathing tests, so I don't know what the results were, but at the time he was not really super short of breath. I wouldn't be surprised if he had some deficits, but I don't think he was at the point where he needed something like BiPAP.
Could you discuss briefly the second agent, Radicava or Radicava, however you like to say it, as a potential therapy? And do we think that this is better than Riluzole, or any better, or should we use in combination, or should we be looking at agents with antioxidant properties? I mean, would somebody consider putting this patient on Tecfidera as an NRF modulator for both conditions? Or do we really have nothing terrific to really offer him? Again, the second agent being Radicava.
Right. Yeah, so, I mean, I don't think we have any great options to offer him. I'm not as familiar with the studies of Radicava or Radicava. I'm not sure how you pronounce it. But yeah, no, I don't think we have great options for.
Well, there's no comparative study between the two, and neither of them are spectacular. So, I guess you could try one and try the other. You could argue, if you're looking for antioxidant, you could put them on Nuedexta. Okay, so Nuedexta, not because he has pseudobulbar affect, though he has pseudobulbar, but everybody thinks about the dextromethorphan as an NMDA receptor blocker. Turns out it's also a sigma-1 receptor agonist. And there is evidence there's a familial ALS that's associated with mutations in the sigma-1 receptor. And at least in vitro, sigma-1 receptor agonists and in animal models seem to help both oligos and neurons. So if you're really desperate, you could give them Nuedexta. Probably no better or worse than the other stuff that's approved.
It's been a little bit of literature on dimethylfumaric acid, and again, here I'm talking about Tecfidera, but with respect to oxidative stress and motor neuron culture preps, so not a lot of data in humans. But,
right. But in mouse models, the SOD1, there are some evidence of some of the sigma-1 agonist experimental ones having some effect. Nothing great to offer him, as Brandon said.
Yeah. Right. Anybody on the phone want to make any comment about stem cell biology as a potential therapeutic intervention? Because we're talking not just about ablation and reconstitution or just getting stem cells re-engineered, but we could have theoretically a discussion about even Lemtrada as a reboot and a stem cell autologous bone marrow stem cell reconstitution or a reboot. I'm not advocating for that. I'm advocating for discussion about that potential principle.
You think that the stem cell is basically protecting you so you can get massive immunosuppression? It doesn't make any sense in this gentleman because his inflammatory microglial response for his ALS is not going to be involved with that, and his MS is benign. So if you believe that intrathecal injections, some of the stuff they're doing in Israel, Eva Feldman's talking about, that's a different issue. But Eva was looking at spinal cord injections. This gentleman, his big problem is pseudobulbar bulbar, and that's the one thing they're not obviously injecting.
Right.
Right, and our other concern,
Elliot, maybe a question for you, or maybe Lindsay as well. Any thought in terms of Ampera? And I know his MS isn't the biggest issue, and obviously it's studying Morgan Gate. I was actually just kind of Googling right now. It looks like there is kind of a study at Cornell that's looking at it in primary lateral sclerosis. some sort of kind of dual effect here, whether or not that might be some symptomatic relief.
Right. So, so in this particular case, we're talking again about 4-aminopyridine as a potassium channel antagonist. Then would there be benefit in prolonging action potential duration? There's of course been a lot of controversy about how much activity you want, whether it's exercise, this or that. Would we potentially accelerate motor neuron burnout versus reconditioning, or is the prospect for plasticity? So the answer is I don't know, but it certainly does sound at least enticing from the symptomatic standpoint, from the standpoint of weakness, and would this guy have better capabilities? There are other facets of this that would seem to either be positive or negative depending upon how you discuss the situation, but it's all mostly still going to be hypothetical.
And I just wanted to chime in to say that this gentleman would really benefit from a nutritional consult to optimize those antioxidant factors that we're discussing about. The other issue that may be interesting to bring up with him and family is because he's presenting with both of these conditions, may be interesting to look at exome sequencing to try to identify genetic markers. It's not going to help him, but may be interesting diagnostically to know for the family to help understand this condition and to understand why he got 2 hits.
Yeah, those are great points. Esther, could you comment a little bit about, we have a few minutes left, but just on the nutritional biochemical specific.
Guys, I'm going to have to bail and head home. So this has been a great, and Brandon, thank you for presenting this very fascinating, unfortunate gentleman. I'm going to run. I'll speak to you guys later. Take care.
Thanks, Bob. But Esther, I was thinking maybe you could discuss some of the specific nutritional factors that, if you were the nutritionist, what kinds of things would you be recommending?
So we know that there are a lot, there's a lot that's being looked at in terms of gut dysbiosis and microbiome inflammatory factors that can lead to a number of diseases, including MS and ALS. And in terms of environmental factors that would change the microbiome, those would include things like red meat, which is more inflammatory, of course, fast foods, high-fat diet or Western diet, high salt intake, and then more beneficial factors, making sure that his vitamin D is in a good range, getting more omega-3 fatty acids on board, and minimizing perhaps gluten types of foods, eating more salmon, which is rich in vitamin D, getting more fruits and vegetables in terms of their antioxidant effects. So would be good, I think, for him to maximize those non-side effect related treatments.
And with your last point, a special emphasis on fruits which are high in composition of polyphenols, like blueberries, blackberries, raspberries, which may not be sufficient with a standard dose that you might take with a meal, but certainly we have options today in terms of supplements to escalate those concentrations. So those are all really great points. Okay, Brandon, I'm going to give the last few words to you. It's hard to believe that we're at 5:43 and potentially going to finish on time. Almost impossible to imagine, but here we are. What final comments do you have, and what is your plan and approach for this gentleman?
Right. So our main discussion with him is whether or not he needs disease-modifying therapies at all. And our concern with all of them really was the increased infection risk, especially given his aspiration pneumonia, well, his aspiration. And so he ended up getting stopped. Tysabri got discontinued. The neuromuscular clinic is the primary driver of his care at this point in time.
Okay. Any other comments from the field? Ed Fox, any comments? This is, you're a patient. Let's say it's we all agree it's benign, many years of benign MS. We've got the ALS story that's overriding. Anything that you would recommend in the way of DMTs or prescription, or would this be primarily supportive and nutritional?
No, I think that yeah, the nutritional and supportive measures are sadly what we have. I mean, the riluzole and other treatments for it, I'm hoping are going to be advancing with the new FDA-approved drugs. I think it's fascinating to again think about that MRI and the appearance over time. Just how much white matter involvement there was and how much atrophy there was, and yet how benign the appearance seemed. And if we looked at the spinal cord and really had good imaging study and saw that there had been a tremendous loss of motor neurons, and we were seeing this retrograde changes that are taking place. And there's some distinctive patterns you can see on high quality MRIs with ALS. It's just, I think it's a fascinating case to be able to look at it and say, if you just looked at the MRI and didn't know much else about this patient, you would never know what that exam showed. I mean, this is really, there's such a disconnect between MRIs and clinical. This really puts a point on it, though.
Yes.
Yeah, I think you do make a very good point about the inadequacy of the neurologic examination and how detailed other examinations are necessary to make sure that before one calls this benign MS, that it's truly benign. And that is neuropsychological assessment of cognition and actual determination by OCT of how much loss there was of the retinal nerve fiber layer, because we know that those factors, retinal nerve fiber layer, ganglion cell loss, leads to impaired quality of life and low contrast letter acuity. So I think before we make the diagnosis of benign MS, we have to do a complete assessment with the currently available tools.
And you might extend that also, Stephen, I agree with you too, looking at genitourinary dysfunction, what do we know about bladder mechanics, assessment of mood, and then as you and Laura have been advocating for, is the expanded application and the use of the NIH VFQ, the visual quality of life, and the 10-item supplement for efferent motility, nystagmus, and those things. So I think you're right. I think it's not enough to just look at the scan and say you got a clinical radiologic paradox on the clinical side until you really ascertain those systems, which have been traditionally very difficult to interrogate. But with OCT, with neuropsych battery, with the VFQ, the quality of life indices, I think we get not there, but we get better. Our sensitivity, the precision is much better before we make a declaration and say, no need to treat that, that's benign. But you always got to qualify that by whose criteria and what was included in that criteria. So I think your point is...
Can I ask...
This is Laura, is that... I'm sorry, I'm talking at the same time as someone. That's not unusual.
That's all right. Go ahead.
Just we don't know the visual profile of ALS, despite some of our efforts to suggest that some of the, especially afferent visual function, and now I think efferent visual function should be interrogated in ALS. I know Steve and you and colleagues did a study of ocular motility in the past in people with ALS, and I think it's an underestimated part of this disorder, and so that would be another interesting avenue to go along and might affect what we would have seen in this.
For in terms of for management for these patients, would you recommend to do like a repeat MRI and see if there's any inflammation that will like prompt to maybe suggest that he may benefit from treatment?
Yeah, we didn't see any enhancing lesions on the repeat, which was done. Although you're right, a year prior he did have an enhancing lesion within the left brachium pontus. But again, our thoughts were that ALS was the primary driver of his symptoms, and so our concern was that given his aspiration, that we would be really worsening his quality of life and increasing the risk of harm if we put him on and an immunosuppressive agent.
Right. But I think the last caller's comment is so important because Brandon, one of the things I think you likely would agree with, let's see, is that there's a lot of heterogeneity with respect to ALS and duration of life. And while we would say this is the diagnosis you don't want, there are clearly people who are alive for a number of years, and in some cases many years. And I think, as Galetta and Laura were just making the point that, you know, we really want to dig down deeper to make sure that we have this right with respect to MS. There's always more to lose, and time is tissue. And if this person lives substantial number of years, because you guys do a great job with management and with nutrition and maybe trying some of these agents, this could be one of these people who could really live for quite a period of time. What we don't want to do is overlook and marginalize that MS diagnosis, particularly knowing in retrospect we did have an enhancing lesion last year. So we clearly know there's still this proclivity to have activity, which means if we have activity in eloquent sites, there's more to lose and there's more to compromise. So yeah. I think the key with treatment, though, is to counterbalance, as you just said, this risk of immunosuppression and risk of infection with the potential counterbalance of disease-modifying therapy benefits. And for example, with Tecfidera and it being an agent that may have effects on NRF and oxidative stress pathways, we can follow the lymphocyte sets and make sure that we don't have lymphopenia and get ourselves into other trouble. Most patients don't. So, and again, I'm not advocating for one or the other. I'm just saying that there are a number of options that we could still consider to be employed in this patient. And also, I think doing so says something to the patient and the family with respect to, we're not giving up on you. This is not necessarily a death sentence. We're going to think about things, try things, and we'll discuss it and see whether we are convincing you that we should do this together. But I think the key is to at least be having that discussion.
Yeah, absolutely.
Yeah. So I think I'm going to take chair's prerogative and bring this meeting to a close. I want to say first, Brandon, that was a fabulous patient with a real dilemma, really met criteria for a dilemma. We all have potential dilemmas, and this clearly is one of them. It was a fabulous presentation. You guys did a great job. But to me, most conspicuous about this call was the amount of involvement and give and take and contributions from the other fellows and the faculty mentors that are on. And this is really one of our big objectives, is to get as much input from as many people as possible, irrespective of their perspective or their point of view. After all, the most important thing is for us to optimize what we do for these very deserving patients and their families. And I think we achieved that today, and look forward to hearing some feedback as we go forward in terms of how this patient is doing and what you guys actually did. And that'll be part of this program too.
Great, thank you.
Great. Fabulous. So without ado, I'll bring this to a conclusion. And Doris, do you have any housekeeping comments to bring us to a close?
No, that is it. I will get the recording posted on our webpage, hopefully by the end of tomorrow. So make sure you check it out.
Okay. And everybody who's presented, I know Andy Romeo was on, and Veronica, and of course, Brandon, you're our newest. Stay tuned. We'll be in touch as soon as we get confirmation from the MS Society, and Neurology N2. We'll be in touch about preparing the CPC version of these proceedings for publication, and we look forward to working closely with you guys on doing that.
Great.
Great. Fabulous. Okay. Good night, all.
Thank you.
Good night, everyone.
Good night. Bye-bye.